Today, our topic is about COVID 19 and what do we know now in 2023. It's been some 3 years. It's hard to believe that we heard about that virus called COVID 19. So, there were a lot of things that were told to us back then that we actually have looked at in terms of a lot of evidence and data. So, the story that we were told initially is not really the same it is today.
Big topics, big ideas, and practical policy solutions. This is Leaders on the Frontier with your host, David Leis.
As Canada begins reflecting on lessons learned coming out of COVID 19, we want to get into some of that data, and we want to do that with the help of an extraordinary researcher, a leader, Deanna McLeod. So I want to welcome you, Deanna. She is a medical peer review publications expert. These are larger words to describe an evidence-based data analysis expert. Again, another phrase that denotes a scientist who's the principal and lead strategist at Kaleidoscope Strategies. Welcome, Deanna.
Thank you, David, for having me on your show.
Well, Deanna, I'm just fascinated with your background because you truly are a scientist that I think comes at the whole issue of understanding COVID-19 and really helping us as Canadians understand what's all happened and where we're at today. So I really do appreciate you joining us. So we've got a pretty far-reaching conversation, but I want to begin with a question. And that is, do you remember, Deanna, I could ask where you were when you first heard about COVID-19, but what went through your mind as you started hearing more about what COVID-19 was about?
I think that, as with everybody, I was a little taken aback, could it really be that we're in the midst of a pandemic and, are things as dangerous as they seem? And the headlines were quite alarmist. So, a lot of it was, I'm going to try, I took on the position of, as an expert in this particular discipline of cancer, I'm going to trust my public health officials to be navigating the data and making good decisions in the public health sphere. And I think that that's what a lot of people did. They basically assumed that we had professionals in place and that they were going to make appropriate recommendations and review the data appropriately. And so, with lockdowns, because we have a virtual business, I have a virtual business. Our whole team kind of retreated to the cottage, so to speak. And, as with many people, kind of started to wait it out. But then whenever the lockdowns were prolonged for a good amount of time and, they started this nonsense of masking at all times, I mean, the evidence side of me started to go, I haven't had a chance to review that evidence, but I highly doubt that there's sufficient evidence to support these types of maneuvers.
Was that right? So your antenna went up was it early on, midway point, like after a year, and you started wondering, something's amiss here or what?
Well, in March, I'm a nerd, right? We're in evidence all the time. So the first thing I did was pull the World Health Organization guideline on the rationalization for lockdowns, and I read it. And so I was, the first thing that I thought is, why do we have Chinese propaganda in the midst of our COVID policy? This is strange. This is an unusual intersection. Because in cancer, a lot of the time, any studies that are done in China, what you do is you reproduce them in the Western world in order to make sure that what they've reported is actually accurate, because, there are other influences that might skew reporting in China versus here. They have got ideologies and political views that might make their scientists want to present data in a particular way. And so, it's just good practice to always double check and to reproduce studies on our end. And that's what I'm used to. So I was very surprised to be seeing that we're relying on Chinese data and Chinese scientists to guide something as extraordinary and extreme an intervention as lockdowns. And generally speaking, the magnitude of the intervention, so this one would be locking down the free world, one would expect that would be based on the highest levels of evidence, which would be, randomized controlled trials, and that there was, extensive studying and guideline preparation that had gone into this before you would go ahead and do that, because it's common sense to think that there are going to be lots of repercussions to such an intervention, economic, social, educational, and fiscal. So, I basically assumed and trusted that the specialists were doing it. But the first clue that I had was whenever I picked up that World Health Organization guideline that was recommending lockdowns, and it looked like Chinese propaganda.
Okay, that's fascinating. So you were on the case fairly early on, Deanna. So speaking of the case, what we'd like to do now is bring up some slides and briefly move through them fairly quickly to just highlight some of the story that needs to be told around data and what the implication is. So can you start taking us through? And it's interesting, the title is The COVID-19 Crisis Political Science 101. Why did you call it Political Science 101?
Because I think that we've arrived at a point where there's a new type of science that's at play. Again, my background is evidence-based medicine, and I was trained in that, and I've been working in that discipline for years, where studies are weighed and guideline recommendations are made. And when you're making a recommendation, you need to factor in the way that you phrase it, both the level of evidence. So, how sure we are that the effect that we're seeing is related to the actual intervention in question. And usually that's a large randomized controlled trial comparing the intervention to a standard of care, right? And so then you'd make that comparison. And if you're sure that this difference is due to the intervention, then you would say that's high levels of evidence. And then you would basically show that to a broad number of experts. Again, in my discipline, what you'd want to do is send it across multiple medical oncologists if it's chemotherapy, or multiple surgeons if it's surgical intervention. And then they would all say, the level of agreement is above 80%. Therefore, it's a strong recommendation. And so you would never proceed with anything that's extraordinary, like locking people down, without that type of evidence. And you certainly wouldn't make assertions publicly like lockdown save lives if you haven't measured that in a well-designed trial and shown that mortality is lower. So when I'm calling it political science, what I'm seeing here through the COVID crisis is basically science that's been manipulated to meet a certain direction or a political aim. I'm calling it political because I can't imagine what else it is. Maybe it's financial or whatever it is, but it seems as though there's entities that had a design that they wanted to see these particular things. And then they did is they worked the science around what conclusion they actually wanted to arrive at.
That's amazing. So you're saying that in your world, as a scientist focused on healthcare, helping healthcare practitioners make good decisions, you've got to be very rock solid on evidence and facts. And what you've figured out in the COVID-19 story is that something else was going on. There was a lot of manipulation of that information. So, okay, well, that's an amazing story. Well, let's dive in and let's look at the first slide then.
Yeah, so the perspective that I would like to share with your audience particularly is layering in the marketing or the financial, the pharmaceutical perspective, because I don't think a lot of people really understand how that's influenced where we are. I was thinking maybe I shouldn't have called it political science, but maybe I should have called it financial sciences, or, something along the lines of, science designed to make things seem one way that is going to profit a certain group of people. Maybe we can save the guessing on who's profiting from this to the final slide, because I do have a slide on that. But right now what we're looking at is a figure, and this is a figure that, I basically created for my company a good long while ago. And it, on the x-axis you have time, and on the y-axis you have treatment uptake. So the blue line there is, we can imagine that is uptake would be equal pharmaceutical sales. So, as a drug gets adopted, so when it's in the development stage, so you've got phase 1 and 2 data, or a phase 3 trial, when it's in development and they're being studied, there's no sales. So there's no uptake of the drug. However, once the phase 3 data is available and it's positive, and it's approved by Health Canada, then what you do is you have uptake via academics initially. So they're the first ones to adopt. And then generally speaking,
Sorry, the
pardon?
people in the
Yeah,
universities.
academics are
You're
like the
saying,
people who
yeah,
are specialists. They're doing the research. And then you get
okay.
community uptake would be people who, mostly are treating patients, not necessarily have any personal research agendas. And they're the last to uptake. And then as the community becomes more familiar with the intervention, then you've got increased uptake over time.
This is a very helpful lens to kind of understand the story. Like before you sell anything, like an intervention, like mask wearing, vaccines, any of that, you have to seed or position the case that, well, frankly, out of you need to take this, you need to do this, so we can be okay, right? So
Mm-hmm.
this is a very useful lens to see that.
Yeah, I do. And I think that it's going to make a lot of things make sense. So, what I'm going to argue is that the pre-marketing campaign had the goal of making people understand that COVID was deadly. So
Hmm.
that is the thing. So what they're doing, one of the things that you need to understand, and I'll just do a little bit of a side thing here, is that vaccines are big business. And I'm going to explain to you why vaccines are such big business. When I'm working in cancer, and this is just something that everybody understands, development starts in the very late stages. So if you're, fourth line advanced cancer, you've only got a couple months to live. This is where they do a lot of studies exploring new treatments. They don't really know very much about this new treatment, but they're going to explore it there. And the people who sign on to those studies basically say, I have very little to live. Maybe this treatment will help me, but I'm going to be altruistic to a degree, and I'm going to allow myself, them to experiment on me because I know that my life is short at this point. So generally speaking, as an agent proves to be safe and active, you move it forward very, very, very gradually until only agents that have been proven safe and effective through years of
Mm-hmm.
testing, extensive testing, are then used on people with early stage breast cancer. Because we don't want to worsen the outcomes. We already know that they have cancer and that that's very difficult. So we don't want to add treatment burden onto cancer burden. So, you have this very systematic approach. Now, interestingly enough, your market, the amount of money that you can make is dependent on the amount of money you can make is dependent on the market. So in advanced cancer, you have a very small market. There's only a few people who are very close to death, whereas, or late stages. And then you have an earlier market, which is people who've just had surgery and they're likely going to live 10 to 15 years. And so generally speaking, drug companies want to move their product to the earliest stages possible to get the biggest market. But vaccines are completely different, because vaccines, what you can do is you can start with an experimental treatment. And then basically, because you're arguing that it's going to prevent disease, you're able to give it to healthy people, which is an extraordinarily huge market. So you can argue that everybody needs to have disease prevention. And so because the market is so big, even if the cost of the agent is small, the amount of money that you make is extraordinary. And the beautiful thing, and I'm saying this in a certain perspective, but the great thing about vaccines is that, when you're dealing with treatment, you actually have to profile the patient and prove that the treatment works. Whereas with a vaccine, all that you have to do if you want to sell it is make somebody afraid of the worst outcomes. So the goal of a vaccine campaign specifically is to portray the worst possible outcome and make people who are healthy and not necessarily at risk feel afraid of that particular outcome. When I started to look at the headlines, what I noticed was they were very alarmist, such and such, so-and-so dies, if anybody died, all of a sudden their face would be all over the headlines, right? So-and-so died from COVID, and, emergencies are overflowing, and then you get very sincere doctors, coming in and say, yes, my emergency is overflowing. The information is taken out of context. The emergency rooms in Ontario have been compromised for over 10 years. And during seasonal flus, they're always overflowing.
So what do you mean they're compromised? In the sense that they're all struggling,
They're
right?
under-resourced.
For years, they've been struggling.
Yeah, they've all been struggling. Yeah. So, out of context, right? So you can just zoom in on that one little thing uh-oh, I had a COVID
Hmm.
case and my emergency room is overflowing, and that's what hits the headlines. So that very selective, that very biased, focused, made me think that somebody was orchestrating this, because we were only ever seeing that one particular perspective. And just on that
Interesting.
note, when we're thinking about COVID being deadly, and I'm 100% sure that all of you can imagine the headlines that we saw. I mean, people were terrified, right? I remember the John Hopkins dashboard. I don't know if you ever saw that one, David, but
Yes, I do. I remember
yeah,
that very well.
I love that one because, it was always the worst case scenario. It was always cumulative deaths, right? So it didn't matter if the deaths were like, the very beginning of the pandemic and that the deaths had come down dramatically and we were all
Mhm.
safe. Looking at cumulative deaths kept that concern about COVID at its height, right? It's like this
Mhm.
many and this many. What you really should be
Yeah.
looking at is the number of events over time.
And I should just remind people, because it seems so long ago, but there was
Yeah.
a model done by a number of them. I can mention them all by heart, but one of them, the most famous one, that predicted literally hundreds of millions of people would be dying around the world. So this was definitely the narrative was that COVID-19 is deadly, and this is going to be like the Spanish flu or SARS-2 on steroids. It's going to be a very high mortality rate and very, very infectious. That's going to go around the entire world very quickly. That was the narrative, right?
Yeah. So this slide here, I just want to bring to your attention because on the left, this was a study that was published. And one of the things that we do the moment we start an investigation is you always look at the mechanism of action or the pathophysiology. How is it actually acting in the body?
Hmm.
And what is the mechanism of action, so that you can kind of appreciate and understand, who's at risk and who's not at risk. And this paper here on the left, I found this schematic, and it's particularly brilliant. On the left hand side, it talks about a young person who's contracted COVID-19, and their innate immune system kicks in. It's the top left-hand corner of that particular figure. Their innate system kicks in, and it activates, and it very much limits the amount of virus that can actually get into the upper airways. And that's, you don't need any antibodies or anything. That's your innate immune system. You've got, a strong reaction. And then if there is a virus that gets down into the lower part of the lung, you've got antibodies that identify and neutralize that virus. And it never actually gets into the cells, the epithelial cells, and it never enters into the blood. So for the most part, anybody with a robust innate immune system really was not at risk of any severe outcomes from COVID, because the virus never got into their blood. And it's only whenever it
Hmm.
gets into their blood that you actually get things like coagulation or inflammation associated with the spike protein that's on the virus. So immediately we were like, okay, so this is going to be, something that's going to affect the elderly based on the pathophysiology. The right-hand panel shows how older people's innate immune system isn't so strong, so they get higher viral load. The more viral load they have, the deeper the virus can go into their lungs.
Okay. So this kind of graph, and it's hard to totally see it there, but basically you're saying that your investigation into COVID-19 could illustrate that it was going to be okay, in the sense that there were particular people, namely older persons with more um, challenged health issues, were the most vulnerable. Is that it?
Yeah, that well said. So, kind of bringing it down, every young people's innate immune system is strong enough to halt the virus in its track, and it basically has minimal effects.
Okay.
Whereas older people, they don't have that same innate protection, and so they're more susceptible. And so, what we were going to look for then, based on that, was probably some deaths in the elderly, and that's what we're showing
Okay.
on the right hand side there.
All right. So protect the vulnerable, namely the elderly. Don't vaccinate the kids and healthy adults. Is that it?
Yeah, or so I mean, I think that's multifaceted, right? Because before we, I probably wouldn't even recommend vaccines at any point in a pandemic. I'm really not sure what the logic is there, because you've got a
Mm.
circulating
Hmm.
virus, and so you'd probably be driving it to mutations, which
Hmm.
some could argue actually happened.
This is stunning. I think most Canadians would be shocked to hear this kind of perspective, because totally taking this COVID story and kind of putting it upside down.
So again, when we're looking at the mechanism of action, we're thinking, okay, is it even plausible that this is going to help? So we know that it's going to cause autoimmune reactions. But the other thing that's interesting about this is that the mucosal membrane, like a respiratory infection, comes in through the mucosal membrane, and it's a separate system of immune response where it's a mucosal. It's like the mucus in your airways traps the virus, and then you've got an innate immune system. And then the mediator is IgA, not IgG. So these vaccines are producing the wrong antibody, the wrong type of antibody to be able to fight infection up here. And in fact, those antibodies that it's producing in your body aren't even able to get up into your respiratory system to help out. So again, from our perspective, when we began to look at the data, we basically said, okay, we're going to expect a lot of side effects, and we're going to expect low efficacy. And so what I have here is our classic level of evidence, and it might be a little bit too complicated for your viewers, but if you're going to make a strong recommendation, you want to be up at the top at level 1. And you want to have a randomized controlled trial that's proving that this thing works. So we looked at the randomized controlled trial for Pfizer, and we said, this is the lead trial. Is it actually showing that it works? And, of course, in the headlines, it's 91% effective for fighting, symptomatic COVID, and it's 96% effective for severe COVID. So it's not going to, it's going to keep you out of the hospital. So these ideas were planted in our minds. But one of the things that they didn't actually look at, which is striking, is they didn't actually look at transmission. And so in order to be able to justify mass vaccination, you actually have to show that it actually stops infection, and you can't share it. And they never did that, David. They never actually looked at transmission, and it was in the actual study itself. So there was absolutely no basis at any time for a mass vaccination rollout because they couldn't prove that it stopped transmission.
Wow.
So there was no evidence for that. So they should not be calling it a vaccine by any normal standards and they certainly couldn't justify mass vaccination.
In your mind, and I know we only have so much time here, but what is your conclusion then? Like the role of funding or conflicts of interest here? What's your conclusion here ultimately, Deanna?
Yeah, I think that again, I was saying that I'm arguing that this was a very elaborate marketing campaign. It had the marks of a marketing campaign right from the beginning. Lockdowns and masking and the horrific headlines were all designed to underscore the need for the vaccine. The data, the way that it was presented and the way that it was marketed was more like a marketing campaign where they're minimizing safety issues by manipulating the data or showing it in a certain light, and maximizing benefit by showing that they always show the efficacy in the best possible light and the safety in another light. So when you see those types of things, to me, it was thinking, okay, so something's actually happening here. Why is our public health acting like a pharma company? Why are they doing why are they acting in the role of pharmaceuticals? And so our team basically started looking at conflicts of interest. So a conflict of interest is basically when there's another party who's standing to benefit financially from a certain outcome. And if they have sway over the recommendations that are being made, then that could actually influence how that's done. And I just want to, this is an elaborate picture of what's happening, but I think that what most Canadians and even our medical institution isn't aware of, that in the last 10 years, we've moved from being a national pharmaceutical strategy to global pharmaceutical strategy. Most of the strategies are cooked up at a global level and deployed in all the different countries simultaneously. And they pick their best and their brightest, and they put them on the global team. And these people do that. So we follow what happens in the states CDC and the NIAID very closely. And what we probably don't realize there is that the scientists there, and for instance, there's scientists there that have the patent for the spike protein that's being used in these vaccines. Every time a vaccine is used, they benefit, they profit, they get royalties from it.
Well, so I guess as we look at this kind of information, Canadians are really confronted with for themselves, thinking through how valid this perspective is. And it's certainly part of the COVID-19 story. So as we look at bringing this to a close, Deanna, Where do you see hope, and what kind of recommendations do you have for Canadians as they look at this and say, what can they do as they look to action in dealing with this?
That's a really great question, David. And I think that we all need to become a little bit more savvy. One of the things that I would say was true for myself is I just implicitly trusted my public health officials and thought that they had my best interests in mind when they were making their recommendations. But I think it's really important for everybody to make sure to check the facts and check the evidence and check the story to make sure that it lines up. From a leader perspective, we need to be looking at these conflicts of interest and looking at the policies, and we need to hold the people who've made those changes accountable. And we need to analyze, to do a postmortem, to figure out what influences were at play, to shut the doors to those influences moving forward, to make sure to bring that decision making back down to a lower level, a decentralized level, where people who can see and respond quickly and make interventions and weigh the evidence can double check the people who are making the recommendations and move forward that way.
Deanna McLeod, scientist and leader, thank you very much for your courage and for bringing us this very fascinating overview around COVID-19. Thank you very much for all your voice on this important topic, and all the very best to you.
Well, thanks very much, David. Thanks for having me on. I hope this is beneficial to your viewers.
Thank you, Deanna. And thank you, everyone, for joining us today for this discussion regarding this important topic. We want to welcome you to get involved with Frontier if you're not familiar with us at our website at www.fcpp.org. Be sure to subscribe to our newsletter and be sure to continue to look at this important issue, particularly through the Citizens Inquiry effort, as Frontier is a partner with that effort.
Thank you for watching Leaders on the Frontier. We're a nonpartisan think tank. We explore ideas, policy, and practical solutions that can make a difference in the lives of Canadians. We do not accept any government funding. We work for you. Thank you for supporting Frontier. Visit fcpp.org to give. While you're there, be sure to check out our latest articles and research. Without open discussion and debate, you're not thinking, nor are you free. Comment below. We'd love for you to join the conversation.